Bismillahirrahmanirrahim. My name is Dr. Nasar Khan. I am Associate Professor of Psychiatry, retired from Services Hospital as Professor of Psychiatry, now working in Queen's University, Canada. Today, our topic is antipsychotic. We will try to continue it from the place where we dropped the last time. So, we will begin with the topic of antipsychotics, uh, atypical and typical, or overall, what I was saying it earlier, it's a treatment for psychosis or schizophrenia. So we will begin with today's presentation. Now, when we talk about antipsychotics, there is a whole array of medications available in the market in Pakistan and abroad. Some of the medications are not available in Pakistan, which are atypical antipsychotics, but most of them are. So it's divided into two classes, the typical antipsychotics and atypical antipsychotics. Typical antipsychotics include phenothiazines, for example, flufenazine, जो Modicate के नाम से is available in Pakistan. It's very much, it's still available, but unfortunately, it's not widely used except in certain institutions. Chlorpromazine is again still available in the market by the name of Largectil or chlorpromazine, but mostly it is not used because of its side effect. Thioridazine was discontinued, which was called Malaril. I was watching one of the presentation by Dr. Kamran and Asghar, and he also mentioned about some of the medications when he was talking about the treatment of catatonia. So chlorpromazine was used for a very long time, both in injectable and oral form in Pakistan, but now it's practically obsolete. Some people still do write it. Butyrofenones, and among that, droperidol and haloperidol. Haloperidol is available in the markets, is still used. When I started practicing psychiatry, haloperidol was a new drug at that time, and it was very frequently prescribed to most of the patients. Surprisingly, the dosage of the haloperidol is reduced over the period of time significantly because of multiple side effects. Previously, we used to give haloperidol 5, 10, 15, 20, 40, and up to 50 milligrams per day. But now we don't go beyond 6 milligrams per day because over the period of time, the research has shown that the haloperidol occupies the receptors 80% on just 6 milligrams. So we don't have to go beyond 6 milligrams. So if the patient responds, he will respond on 6 milligram. If he is not responding on 6 milligrams, only the side effects will come in, not the therapeutic effects. So it is not prescribed anymore in a higher dosages. Then thioxanthines, which include thiothixine and chlorprotixine, are also not available in Pakistan. There are a few other typical neuroleptics, especially in depot preparation, like zooclopentixol, clopentixol, flupentixol. Those thioxanthines are still available in the market, and they are used in acute cases as well across the globe. The difference between the depot preparation and acute-phase is the solubility of the drug in vegetable oil and other oils. So the long acting and the short acting depends upon its absorption from the site of the injection. We will talk more about it. The atypical antipsychotics include the clozapine, the risperidone, sulpiride, lorazepam, olanzapine, quetiapine. There are a few more names which I will come later in the presentation. So we will keep on talking about these drugs over the period of time. Okay, so right. Now, this classification of the drug is mostly dependent on the site of the action of the medication. So the pyramidal tracts, the lateral corticospinal tract, the anterior corticospinal tract, extrapyramidal tracts like rubrospinal, reticulospinal, olivospinal, vestibulospinal tracts, they are all site of the actions of these drugs. Unfortunately, these drugs may cause the side effects acting on pyramidal or extrapyramidal tracts. Sensory and ascending afferent pathways like dorsal column medial lemniscus system, spinocerebellar tracts, anterolateral cerebellar tracts are all part of the process of effect of antipsychotic. The main target of efficacy depends on their occupancy of receptors at dopamine D1, 2, 3, 4, and 5. Now, these are the dopamine receptors. Serotonin includes 5-HT-A1, A2, 3, 6, and 7. Norepinephrine receptors occupancy by these antipsychotics is on norepinephrine 1 and 2. Muscarinic acetylcholine receptors includes 1 and 4. Histaminergic receptors includes H1 and H2. Dopamine, norepinephrine, serotonin transporters, and NMDA glutamate receptors. All of these receptor sites are the drug targets in treating psychosis or, again, schizophrenia. Some people respond to the drugs which affect more on dopamine. Some people respond to the drugs which have more occupancy on NMDA glutamate receptors. Some of the new drugs have good effects on these receptors. Now, as I was talking earlier, our target is not the receptor occupancy. Our target is receptor affinity. If there is a receptor occupancy, then the patient may get well from psychosis, but he won't enjoy his life cognitively, emotionally, and physically. So, if 80% of the receptor occupancy is achieved, the psychosis gets well. But unfortunately, the 80% receptor occupancy won't correct the cognitions, emotions, and reactivity physically. So, Hamara overall theme is not the receptor occupancy. Our overall theme is receptor affinity. One of the questions asked sometimes in a group that what do we need to do? We have to go for receptor occupancy, like super sensitivity of the receptors and treatment of psychosis, or receptor affinity. So this is a typical example. Our target is to make sure that the receptor affinity is in such a way that the patient is happy, joyful, working, and emotionally comfortable. If we won't be able to achieve this, then we won't be able to achieve the target. The basic pharmacokinetics of all antipsychotic is like this, that is under area under the curve. So when the drug is taken, it goes to a peak plasma level. It is absorbed from the intestine. Now, from where most of the antipsychotics are absorbed, it is the first part of the small intestine, which is jejunum. So after it passes through the stomach into the duodenum and goes to the first part of the jejunum, that is the most important part of site of absorption of most of the antipsychotic. Some may vary. So some drugs are absorbed more from the duodenum or the ileum, but mostly drugs are absorbed from jejunum, first part of jejunum. And when they are absorbed, they are taken up and then they are attached to the plasma proteins. The drug goes into the liver, passes through the first pass metabolism in the liver. Some of the drug goes from the liver into the systemic circulation and goes to the target organs. With some of the drug goes back into enterohepatic circulation, where it is excreted back again in the intestine and then again taken up from the jejunum into the liver to have the second pass metabolism. Now, this cycle of absorption going into the liver, getting metabolized into the system, getting back into the intestine, absorbed back again, and then going into the systemic circulation is a very complex mechanism. So, whenever we are prescribing a drug to a patient, we should be able to understand that this drug in this specific patient, this much will be absorbed and go into the system right away and have the receptor occupancy. So अगर कोई पेशेंट मेरे पास आए और मुझे कहे कि ये आपने जो दवाई दी थी वो मैंने खाई और मैं तीसरे दिन ठीक हो गया, so this means कि उसकी absorption from the intestine going into the liver, getting metabolized and going into the receptor site is quick, and sometimes it's slow. But overall, whenever this whole process goes, the area under the curve, overall drug exposure and receptor sensitivity goes to the peak level, C max, which is called the concentration, which is the maximum, highest concentration of drug in the blood. It takes usually about 3 weeks. So sometimes the maximum concentration of the drugs is achieved early, sometimes it is achieved late. But considering the overall pharmacokinetics, the personal variations, the body physique, the way the intestine absorbs the food and the drug, and the way the liver metabolizes the drugs, it is all very different from individuals to individuals. But to understand the whole of the situation, Cmax is the highest concentration of the drug in the blood. Half-life, when this maximum concentration reduces to the half of the level, time at which drug has lost half its maximum concentration is the half-life. And C minimum is the lowest concentration of the drug in the blood. Now, if you just overall keep this picture in your mind, कि कोई भी दवाई जब आप खाएंगे और वो यहाँ से अंदर जाएगी, so it will passes through the esophagus, into the stomach, into the duodenum, first part of the jejunum, absorbed, goes into the liver, then some of it is metabolized, goes into the system, some of it goes into the enterohepatic circulation, some of it is just excreted out through the bowel, some of it is excreted out through the kidneys. And in blood, when its maximum concentration is achieved, it passes through the blood-brain barrier into the brain, occupies the receptors, and it starts its effect. Now, again, मैंने कहा कि इस सारे process में person to person is a variation, individual to individual is a variation, dependent on the body physique, dependent upon the daily lifestyles, dependent upon the food intake, dependent upon so many other factors. So ideally speaking, most of these curves are made hypothetically, not in a real-time situation on the real-life patients. So real-life patients can vary from person to person. I hope you people are still able to see the slides. Okay, moving on. When we talk about this, why individual differences are there, why there is a difference in the effectiveness of the antipsychotic, why one person responds to one drug and not the other person to the same drug. These variations are very much variable on various situations. So I hope you are able to see this. Bioavailability of the drug is dependent on area under the curve after oral administration divided by area under the curve intravenous administration. So कोई भी दवाई जब orally कोई खाएगा उसका area of under the curve जो आएगा वो, और जो अगर हम उसी दवाई को intravenously दें वो, उनके comparison से हम bioavailability कैलकुलेट कर दें, लेकिन अगेन दिस इज समथिंग हाइपोथेटिकल. Now, area under the curve, Tmax oral administration, is the concentration of the drug which is maximum, Cmax. Maximum safe concentration is called MSC. Therapeutic range is a therapeutic window between the maximum level of the drug in the blood and the minimum effective dose. Agar minimum effective concentration and maximum safe concentration is balanced, we will get the therapeutic response, and that is the therapeutic window. But if the drug goes beyond that level, which is the pink state, कि आप हेलोपेरिडोल को 10 मिलीग्राम से शुरू करा देते हैं, मे बी उसकी एरिया अंडर द कर्व की मैक्सिमम कॉन्सेंट्रेशन, सेफ कॉन्सेंट्रेशन is at 7 milligram or 6 milligram for that individual, but it goes up to 10, the side effects will appear. If the person maximum safe concentration for the individual is say 20 milligram for haloperidol and he is still at 10, then area under the curve is still low and the therapeutic window is wider. Therapeutic window is basically the gap between the maximum safe concentration and minimum effective concentration. That therapeutic window gives us the maximum response to any drug, right? So this is a little bit complex. If the drug is given in a low doses, like some of the people write sertraline 25 milligram, some of the people write escitalopram 5 milligram, some of the people write risperidone 0.5 milligram. Now those drugs fail to achieve the maximum safe concentration. Those drugs are not able to touch the minimum effective concentration in a person, and they don't have any effect therapeutically. So उनका जो इफेक्ट आ रहा है वो प्लेसिबो इफेक्ट हो सकता है, लेकिन एक्चुअल इफेक्ट नहीं होगा. कोई भी दवाई जब ब्लड में जाएगी, it will reach into the maximum concentration over a period of time, because these drugs, the antipsychotics I'm talking specifically, are highly fat soluble drugs. They are lipophilic agent, highly plasma bound. So plasma boundness, lipophilic capabilities, free ionic availability of the drug, maximum safe concentration, so many factors are affecting in actual response to a person to an antipsychotic. So some people do respond to the lower dosages, but majority, it is the window between the minimum effective concentration and maximum safe concentration, which will be helpful in treating any patient over the period of time. To further explain it, distribution of the bioavailability. So when the blood concentration is achieved suddenly, again, it goes up to the maximum dose, it comes down. The available therapeutic window is short. It goes away soon. It has to be sustained in the system for a longer period of time to reach up to the brain to have a therapeutic effect. So अगर किसी को आप एक्यूफेस का इंजेक्शन लगाते हैं क्लोपिक्सॉल का, सो पेशेंट की बायोअवेलेबिलिटी सडनली बढ़ती है, पीक कॉन्सेंट्रेशन पे जाती है और उसके लेवल्स ड्रॉप करते हैं. उससे जो थेराप्यूटिक विंडो में तो वो फॉल कर जाता है, लेकिन क्योंकि वो ओवर द पीरियड ऑफ टाइम सस्टेन नहीं करता इन द सिस्टम, उसको सस्टेन करने के लिए आपको हर कुछ देर के बाद वो इंजेक्शन दोबारा देना पड़ेगा ताकि वो रिसेप्टर ऑक्यूपेंसी करे और साइकोसिस को एड्रेस करे. अगर हम वो रेगुलर इंटरवल्स एडजस्ट प्रॉपरली कर लेंगे, थेराप्यूटिक इफेक्ट आ जाएगा. अगर हम वो नहीं करेंगे, थेराप्यूटिक इफेक्ट नहीं आएगा. सो कोई भी दवाई जब ओरली मैं खाऊंगा सो अंदर जाएगी, एब्जॉर्ब होगी, लिवर में जाएगी, बॉडी में उसकी कंसंट्रेशन स्टैब्लिश होगी, उसको कुछ वक्त लगेगा. यूजुअली द टाइम इज 7 to 16 hours. Usually for antipsychotics, it can vary from, again, as I told you earlier, person to person. After that, the drug passes through the blood brain barrier and starts receptor occupancy. So, generally speaking, any drug which is given to a person goes into the system, reaches the maximum, comes to the minimum, second dosage is administered, goes to the maximum, comes to the minimum, then again third dose is given, and after a while, after passing through all these phases, the drug establishes a steady state, a level where the concentration of the drug in the blood stays the same, giving repeated dosages at appropriate intervals of time. The steady state is achieved and the therapeutic effect comes in. Now, this is again complicated to understand, but again, talking back about it, the steady state in the plasma is the level of the drug which remains the same over the period of time when the regular dosages are administered in a person. So that steady state will give definitely a good therapeutic effect. Now, half-life. The time required for the concentration of the drug in the plasma to decrease to one half of its initial value after the peak has been reached. It is designated as T half, a usual parameter derived from VD and CL, important for rational drug therapy because it helps in designing and planning the dosage of the regimes. हमारे पाकिस्तान में, unfortunately, without considering what is the half-life of the drug, people give medication 3 times a day. Like risperidone, 1 milligram 3 times a day, or 2 milligrams 3 times a day. Olanzapine, 5 milligrams 3 times a day, or sertraline, 25 milligrams 3 times a day. It never works on that principle. It is unfortunately falsely written as far as the therapeutic effects are concerned. So, if all of these antipsychotics, I hope I have that slide as well, all antipsychotics have half-life of more than 24 hours. Haloperidol, olanzapine, risperidone, quetiapine controlled release, or any other antipsychotic. They stay in the system for 24 hours. So it is no fun considering this principle of giving the drug again and again when the half-life is more than 24 hours. What will happen if half-life is 24 hours, you give a drug, it reached the maximum concentration, it drops down to the half. But if you keep on giving half tablet every 8 hours, when the half-life is 24 hours, this C max will go beyond the therapeutic range, and this C minimum will never ever come to a level where patient can respond. So I'm sorry if I'm having difficulty in choosing the words for it. जब आप बार बार दवाई देंगे तो ये थेराप्यूटिक विंडो कॉम्प्रोमाइज हो जाएगी. सो ये लेवल्स बार बार देने से जल्दी जल्दी मैक्स और मिनिमम के दरमियान फ्लक्चुएट करेंगे और स्टेडी स्टेट अचीव करने में टाइम लगेगा. सो जो एंटीसाइकोटिक 24 आवर्स के लिए सिस्टम में रुकती है, जब वो बार बार दी जाती है तो उसका सी मैक्स जल्दी जल्दी आता है, सी मिनिमम आने नहीं पाता और उसकी स्टेडी स्टेट्स अचीव नहीं हो रही होती, तो उसका थेराप्यूटिक इफेक्ट कॉम्प्रोमाइज हो जाएगा. ये पॉइंट समझ आया? नहीं आया? हमारे यहाँ बहुत सारे लोग दवाइयाँ 3 times a day TDS या BID पे रिकमेंड करते हैं, जो कि एंटीसाइकोटिक्स में एक्चुअली इज नॉट यूजफुल. It is actually counterproductive rather than productive. So try to understand that most of the antipsychotics should be prescribed to a person. Drug half-life, according to the drug half-life, and drug half-lives of most of the antipsychotics is more than 24 hours. So once a day given only in the evening is preferred than dividing the dosage. So drug half-lives vary from person to person. Half-life can vary based on person's weight, gender, health and many other factors. जैसे कि मैं बार बार आप लोगों को बता रहा हूं. So the duration of action of the drug from the peak effect till the time it goes into the brain, occupies the receptors and have its effect varies. But if you give it frequently, this system will be disturbed and maybe adverse effect will come sooner and the therapeutic effects or the desired response is either not achieved or compromised. So kindly, all of you should remember that most of the antipsychotics should be given once a day in the evening because they have long half-lives, so they can have a good therapeutic response according to these principles of pharmacokinetics. Now, talking about the half-lives, aripiprazole, if given to a person, stays in the system for more than 80 hours. So aripiprazole twice a day देने का कोई advantage नहीं. Just give once at a day, preferably morning or evening, whatever time suits you. Clozapine stays in the system for 16 hours. So sometimes we give to a person a morning dose and an evening dose. 3 times a day देने का कोई advantage नहीं. प्लेसिबो इफेक्ट के लिए मे भी हम दे दें, थेराप्यूटिक इफेक्ट के लिए देने का फायदा नहीं है. फ्लूफेनाजीन डेपो फॉर्म में अवेलेबल है पाकिस्तान में, ओरल आता ही नहीं है, स्टेज इन द सिस्टम फॉर लॉन्ग टाइम. हेलोपेरिडोल स्टेज इन द सिस्टम फॉर मोर देन 24 आवर्स. सो हेलोपेरिडोल की गोली आपको 3 टाइम्स या 2 टाइम्स देने की जरूरत नहीं है. लोरासिडोन हाफ लाइफ ऑफ 30 आवर्स. Olanzapine, half-life of 36 hours. Perfenazine, not available in Pakistan. Quetiapine, IR, intermittent release, सादी गोली 10 घंटे स्टे करती है सिस्टम में, लेकिन क्योंकि हम ज्यादातर XR preparation यूज करते हैं, which is extended release, stays in the system for more than 36 to 48 hours. Risperidone stays in the system for more than 20 hours. And ziprasidone is given in a divided dosage of 3 times a day or 2 times a day. ज़्यादातर लोग ziprasidone को यूज भी नहीं करते, लेकिन that needs to be given in divided dosage. So of all the antipsychotics, only ziprasidone is given in a divided dose. The rest of the drugs can be given once a day only in the evening. And that's it. It will have a very beneficial effect of achieving Cmax, remaining in therapeutic window and achieving the steady state without having the side effects. That is important parameter for prescribing antipsychotics. Now, common antipsychotics, again, I'm sorry कि ये slide थोड़ी सी disbalance है. I picked up this picture from somewhere, but so it was not appropriate. Anyway, first generation antipsychotics, again, as you can see, chlorpromazine 35 hours, haloperidol 36 hours, aripiprazole 75 to 80 hours. Now, the half-life can vary 4, 5, 10 hours time from books to books, but mostly it is around the same level, so you don't have to worry about it. Clozapine usually lasts, the likha hai 4 to 12 hours, some books say 20 hours, but overall, twice a day dosage for clozapine is good enough. Once a day, it can be given over a period of time. Olanzapine stays in the system for long term and risperidone around 24 hours a day. So once a day is okay. Now, atypical antipsychotic dosage range for bipolar depression. Now, some of these antipsychotics are used for bipolar depression. मकसद बताने का बाइपोलर डिप्रेशन की ट्रीटमेंट का नहीं है, यहाँ पे मकसद बताने का हाफ लाइफ है. So new drug like cariprazine is used in schizophrenia. It is used in bipolar depression as well. It is used in mania as well. Average dose is 5 milligrams per day. It can be given up to 10 milligrams per day. Cariprazine is marketed here. It is prescribed not very frequently because the efficacy and the effectiveness was not as good as other drugs comparable to the market, and it is not approved with some of the agencies which provide the free medication, so it is not given so frequently. But lurasidone is available, 20 to 120 milligrams per day, and the half life is long, so once a day given is okay. Olanzapine की बात हो गई. Combination of olanzapine and fluoxetine, this is also prescribed in Pakistan a lot, 6 by 25 or 12 by 50, and the half life is long, around 40 hours in the system. So once a day dosage is okay. So it can be given in once a day dosage. Sorry. Okay, moving on. Half-life of benperidone. Now, this is an old drug, not available in Pakistan, so I won't be talking about it. I'll be talking about flupentixol. Oral bioavailability is 55%. Half-life for release from depot injection is about 17 days. So when you give an injection of flupentixol, don't expect the steady states to be achieved soon. The steady state will be achieved after 3 depot injections, which is if you are giving it on a monthly basis in about 3 months. So the misconcept that if I give the depot, the patient will be okay sooner is unfortunately not correct. The effect of the flupentixol injection comes after 3 injections because the steady state is achieved in approximately 2 to 3 weeks time, and after that the receptor occupancy takes further time. So if you are prescribing flupentixol depot to a person, at least 3 injections on 3 weekly interval will be able to give you the desired response. Not before that. You won't be able to take it before that. Perfenazine again is not available. So यहाँ पे basically इस slide को दिखाने का मकसद मेरा flupentixol की bioavailability का था. Indications for switching antipsychotic drugs in patients with schizophrenia. You start a drug, you give it for a certain period of time, you wait for the therapeutic response. The therapeutic response never comes in about, say, 3 months' time, and then you have to change it. Now, the reason why you want to change the drug. 1, poor treatment response, acute illness relapse despite good treatment adherence. Now, how would you know that this drug was given for a proper period of time, for a proper dosage? जब हम कहते हैं poor response to a drug, so एक बात को ज़हन में हमेशा बांध के रखें, poor response never means कि आपने proper therapeutic dose नहीं दी और appropriate duration के लिए दवाई को ट्राई नहीं किया. जो पिछले फार्माकोकाइनेटिक्स के कॉन्सेप्ट्स मैं आपको बता रहा हूं, उसके हिसाब से किसी भी दवाई को देना थेराप्यूटिक डोज की रेंज में देना जो सी मैक्स और सी मिनिमम के दरमियान हो, प्रॉपर ड्यूरेशन ऑफ टाइम के लिए देना जो कि कम से कम 3 से 6 हफ्ते का टाइम है, और ये बात को श्योर कर लेना कि उसकी कंप्लायंस ठीक थी, वो प्रॉपर डोजेज में गई और प्रॉपर टाइम के लिए गई। अगर ये 3 पैरामीटर्स पूरे होते हैं फिर भी पेशेंट ठीक नहीं होता तो फिर हम पुअर रिस्पॉन्स में जुमरे में लेकर आएंगे, वरना नहीं। सो पुअर रिस्पॉन्स टू द ड्रग, एक दवाई पेशेंट को दी आपने, से रिस्पेरिडॉन 2 milligrams per day, and it was given for 6 weeks and patient never responded, never means that he is non-responder to risperidone. You have to push up the dosage to the therapeutic range, which is 6 milligrams to 8 milligrams per day for at least 6 weeks time period, with ensuring the compliance. Only then, if the response to the psychosis was not achieved, you will say that this is not a good drug for this person. Now, this is tricky. हम नुस्खे देखते हैं, रिस्पेरिडॉन का ट्रायल दिया गया, लेकिन हम ये नहीं देखते कि रिस्पेरिडॉन कितनी डोज में ट्राई की गई। ये तो दी ही 3 मिलीग्राम तक दी गई या 4 मिलीग्राम की एक गोली प्रिस्क्राइब की गई फॉर 3 महीने के लिए। इट इज नॉट अ बेसिकली थेराप्यूटिक ट्रायल कंसिडरिंग सी मैक्स, सी मिनिमम, स्टेडी स्टेट, हाफ लाइफ। 2 मिलीग्राम सुबह दोपहर शाम रिस्पेरिडॉन दी गई, 6 हफ्ते के लिए दी गई, 6 मिलीग्राम पर डे दी गई। क्या ट्रायल कंप्लीट हो गया? ना, यू हैव टू टेल मी, कंसिडरिंग व्हाट आई हैव टोल्ड यू, क्या ट्रायल कंप्लीट हो गया या नहीं हुआ? इफ यू थिंक ट्रायल कंप्लीट हो गया, फाइन, वी कैन मूव अहेड। इफ यू थिंक ट्रायल कंप्लीट नहीं हुआ, आई थिंक वी शुड कीप ऑन डिस्कसिंग दिस टॉपिक अगेन। Acute illness relapse despite good treatment adherence, persisting and impairing positive or negative symptoms, persisting and impairing mood symptoms or cognitive impairment, little to no improvement in psychosocial functioning. जो मैंने पहली तस्वीर दिखाई थी बंदे की बैठ के मुस्कुराते हुए, that is the target for the treatment. If we are not able to achieve that target, things are not appropriate. So we should focus on that. Relapse or clinical instability due to poor adherence in an otherwise treatment responsive patient. पेशेंट ने कभी दवाई खाई, कभी नहीं खाई, घर वाले गोलियों को पीस कर किसी चीज में मिक्स करके पेशेंट को दे रहे हैं ताकि पेशेंट को दवाई जाती रहे। Now, how do we know that crushing the tablet can have a good effect? No, it won't have, because these pills are coated tablets. When they are broken into pieces, the efficacy, the half-life, the Cmax concentration, everything gets compromised. We won't be able to get what we want. That's important as well. Intolerable side effects. You have given, say, aripiprazole, 5 milligrams, patient develops akathisia on the first dosage. You cannot keep giving the drug. इसमें दवाइयों के नामों में ब्रेक्सपिप्राजोल भी है, जो which is very commonly written these days here. Severe adverse effects leading to threatened or actual non-adherence, aggravation of general medical condition by an antipsychotic drugs. मोटापा था, olanzapine दे रहे थे और मोटापा हो गया, compromise. So you have to change the drug. Adverse effect burden clearly increase as a result of specific drug-drug interaction. Request of the patient or the caregivers. लोग कहते हैं जिससे नींद ज्यादा आ रही है, इससे बेचैनी हो रही है, इससे घबराहट हो रही है, इससे ये ठीक नहीं हो रहा. So requesting, if the caregivers are requesting you to change the drug, you can change the drug. But first, you have to try to convince them why you don't want to change it and what are the possibilities if you will change the drug. So, and reduce the cost of medication and simplifying the dosing schedule. Now, giving drugs, एक गोली सुबह खाने से पहले, एक गोली खाने के बाद, एक गोली दोपहर को खाने से पहले, एक गोली खाने के बाद, एक गोली रात को खाने से पहले, एक गोली खाने के बाद, एक गोली सोने के बाद. You will make the things complicated. Patient will be confused. I will be confused. And of course, how to take the medication is a problem. Now, lorazepam is always prescribed with the meals because its bioavailability is dependent on specific concentration of the food lipids in the food which are needed for the lurasidone to be absorbed properly, go to the receptor sites and have its effect. If it is given in empty stomach, it won't have a good effect. So knowing each drug and knowing each drug's half-life, Cmax and C minimum, and also the steady state levels is important for a psychiatrist. If you don't know this, you can keep on giving the drug and the patient won't get well. If you want to make the patient get well, you should know these terms, you should know these situations, and you should know what is there which is making you feel that the drug is not effective. Absorption and the distribution. Most antipsychotic drugs are highly lipid soluble and protein bound, 92 to 99%. They tend to have large volumes of distribution, usually more than 7 liters per kilogram. These drugs generally have a much longer clinical duration of action than would be estimated from their plasma half-lives, despite seeing that the plasma half-life of quetiapine IR is say 12 hours or 8 hours, it can stay in the system for 24 hours. कल एक गोली खिलाई थी, आज तक सोए हुए. So it can vary. This is again, these are not my quotings. This is Kedson, the drug of pharmacology की जो किताब है. So make sure that you know these terms. Okay, so that's it for today. We can talk more if you people want to ask any question. Anybody? No? No question? सब समझ आ गई या कुछ समझ नहीं आई? Anybody? चैट बॉक्स में ही लिख दो.
समझ में आया है और काफी चीजें क्लियर हुई हैं, और स्पेशली पुअर थेरेप्यूटिक रिस्पांस के जो फैक्टर्स हैं वो पहले आइडिया नहीं था कि उस इन पैरामीटर्स पे देखना है. और मॉडस्ले में भी हर जगह ही लिखा है कि आपने ड्यूरेशन, कितनी ड्यूरेशन तक कितनी मैक्सिमम डोज पे जाना है, तो काफ़ी चीज़ें क्लियर हुई हैं.
Again, you people, all of you, I am sure that you all will become very good psychiatrists in times to come, and your supervisor are excellent supervisors as well. But please understand one thing. No humans, two humans are alike. They differ because of their DNA. The DNA is the protein. These drugs go and affect on our genes, on our receptors. Receptors क्या हैं? Proteins हैं. वही DNA से बने हुए protein molecules हैं जिनमें उसी पे affect करना है. Individual variations are there. You have to make sure that what therapeutically is required should be achieved. So if a person is taking, say, risperidone, 4 milligrams per day, and he is not responding, I will definitely try to see the factors otherwise. किस टाइम पे दवाई खाते हैं, किस चीज के साथ खाते हैं, खाली पेट खाते हैं या खाने के साथ खाते हैं, दवाई सुबह दे दी जाती है, दिन भर सुस्त रहते हैं, रात को अलर्ट होके बैठ जाते हैं, बॉडी वेट कितना है, बीएमआई कितना है, लिपिड प्रोफाइल कैसा है, टेस्ट करवा के, डायबिटीज तो नहीं है, मेडिकल कोमॉर्बिडिटीज तो नहीं है. सो देयर इज नॉट ओनली वन फैक्टर which can lead to the outcome. There are multiple factors. And if you consider these factors, you will not say that the trial of risperidone was unsuccessful without considering these things. If you will consider these things, and even then the patient hasn't responded, follow the prescribing guidelines, jump to the next one. But prescribing guidelines में ये तो mention है कि ये थेराप्यूटिक डोज है, इतनी ड्यूरेशन के लिए देनी है, और फिर ट्रीटमेंट ट्रायल फेलियर है. लेकिन उसमें बहुत सारी और चीजें मेंशन नहीं है, लाइक बॉडी मास इंडेक्स का जिक्र शायद पूरी तरह नहीं एक्सप्लेन, स्टेडी स्टेट का जिक्र पूरी तरह एक्सप्लेन नहीं किया हुआ, हाफ लाइफ का कॉन्सेप्ट पूरी तरह एक्सप्लेन नहीं किए गए. सो प्लीज ट्राई टू अंडरस्टैंड देम, apply them to your patients, and then see the outcome rather than just saying that the treatment trial was a failure. right? Sorry, go ahead. Anybody was saying anything? Okay. ये तकरीबन अभी
अस्सलाम वालेकुम सर।
वालेकुम अस्सलाम। 14 स्लाइड्स अभी और पड़ी हैं, सो हम इस पे मजीद बात करेंगे नेक्स्ट टाइम। जी जी डॉक्टर साहब, क्या हाल है कामरान?
अल्लाह का शुक्र है सर, ठीक ठाक, एक्सीलेंट सर, बहुत ही अच्छा, बहुत पसंद आया और मैंने बहुत कुछ नया सीखा आज के लेक्चर से। मैं थोड़ी सी और मजीद चीजें ऐड करना चाहूंगा। एक तो ये कि रीनल, जिस तरह आपने बहुत सारे फैक्टर्स बताए हैं, सो सम इवन मोर, रीनल क्लियरेंस, हेपेटिक क्लियरेंस, स्मोकिंग स्पेशली क्लोज़ोपीन के साथ, के जो स्मोकर्स हैं उनमें क्लोज़ोपीन की जरा ज्यादा डोज चाहिए होती है, and that does not relate to the e-cigarettes because it's nicotine की वजह से नहीं बल्कि टोबैको की वजह से है, और एज का अनदर इसमें फैक्टर है। दूसरा सर, मैं जो ट्रेनीज को लिथियम के बारे में बताना चाहूंगा कि और इन एनी केस इलेक्ट्रॉनिक जीएफआर, सॉरी एस्टिमेटेड जीएफआर, ईजीएफआर, वो जरूर रिकॉर्ड करवा लिया करें। आई थिंक लाहौर, चगताई लाहौर लैब, दे डू इट। तो हर लेबोरेटरी नहीं करती, लेकिन ये कि अब सिर्फ यूरिया क्रिएटिनिन पे हमें रिलाई नहीं करना चाहिए, बल्कि ईजीएफआर को भी करवाना चाहिए,
वो
क्योंकि वो
अब
फिर
कॉन्सेप्ट थोड़ा सा चेंज होके, पहले हम सिर्फ यूरिया क्रिएटिनिन करवा के रीनल क्लियरेंस कर लेते थे। जी RFTs, द रीनल फंक्शन टेस्ट आर ओके, but now they say that EGFR is more reliable in determining the renal clearance and renal functionality rather than just urea and creatinine. So जो डॉक्टर कामरान कह रहे हैं, चीजें चेंज होती हैं वक्त के साथ। हम कितने मरीजों का ब्लड टेस्ट करवाते हैं बिफोर स्टार्टिंग एन एंटीसाइकोटिक? अनफॉर्चुनेटली पाकिस्तान में मेजॉरिटी ऑफ द टाइम हमारे इवन साथी कोलीग्स भी दवाई शुरू करा देते हैं, टेस्ट नहीं करवाते। पेशेंट जब हमारे पास आता है तो हम उससे पहली चीज पूछते हैं कि कोई टेस्ट करवाया, और पता चलता है जी 6 साल से दवाइयां खा रहे हैं, कभी कोई टेस्ट नहीं करवाया, विच इज अनफॉर्चुनेट। मेक श्योर that the baseline investigations are the key parameters. So जैसे कामरान ने कहा, renal clearance, hepatic compromised situations, diabetes, hyperlipidemia, any cardiac problem, all of these antipsychotics, most of them, they prolong the QTC interval. Most of them. Not one, but most of them. So we have to be careful. हम दवाई देते चले जा रहे हैं, थेराप्यूटिक रेंज में उसको लाते चले जा रहे हैं, उधर से पता चला जी कोई कार्डियक इवेंट हो गया। एंटीसाइकोटिक कैन लीड टू सडन कार्डियक डेथ्स। सो ये बातें मैं भी मजीद करूंगा इन दवाइयों से रिलेटेड, जो कामरान ने बात की, दिस इज इंपॉर्टेंट। सो हम इसको भी टच करेंगे, बट प्लीज कंसिडर करें कि वो पेशेंट जिसको आप एंटीसाइकोटिक दे रहे हैं वो सिर्फ साइकोटिक नहीं है, वो इंसान है। And you have to treat a human being, not the psychosis, right? So be careful about these things as well. Any other question or comment? नहीं, सब समझ आ गया? Okay. Thank you very much for listening to me, and I hope I will be able to have some more time next week. So I will take the class next week, and we will try to finish this antipsychotic topic. It is still so many other parameters left. I will try to cover them as many as possible, but still, if I miss something, you just let me know. Thank you very much, everyone, for attending. See you next Friday. Allah Hafiz.
Thank you, sir.
थैंक यू सर।